I'm Dr. Eric Johnson. I'm from the University of North Dakota School of Medicine and Health Sciences, where I'm a professor and director of interprofessional education, and I am also the assistant medical director of the All True Diabetes Center, both here in Grand Forks, North Dakota. Dr. Wyrock.
Hi, everyone. My name is Dr. Stephanie Wyrock. I'm a physical therapist. I have my own practice here in Billings, Montana called Movement X, where we specialize in primary care, pelvic health, and orthopedic physical therapy.
Today, we'll be focusing on the relationship between medical team members and physical therapy in the management of these patients. We do not have any disclosures. Here's our learning objectives: to identify individualized patient targets and therapeutic approaches for diabetes management in older adults, to recognize geriatric syndromes, musculoskeletal impairments, and comorbidities in older adults that may adversely affect diabetes self-management and quality of life, to apply current research to best reach optimal prescription of exercise-based interventions in older adults with diabetes, and to integrate an effective team-based clinical approach in the management of patients with diabetes. Target and management goals do focus on primary and secondary prevention in older adults with diabetes, and lifestyle changes can be very important in this process to identify and address barriers to exercise, for self-management education and support, which is a cornerstone of diabetes management, as is nutrition, smoking cessation, and psychosocial care. And coaching can originate from a variety of sources. This also includes fall prevention and maintenance of function, attention to complications and conditions that would lead to functional impairment, like neuropathy, for example, nutrition management and intervention, social determinants of health, and psychological screening on a routine basis for mild cognitive impairment, depression, anxiety, and dementia. Diabetes complications really fall into two large buckets. One is macrovascular complication or large vessel disease, and this includes cardiovascular diseases of coronary heart disease, stroke, and peripheral arterial disease and amputation. Cardiovascular disease is the biggest killer in adults with diabetes. Then there are microvascular complications or small vessel disease, which includes retinopathy, nephropathy, and neuropathy. Avoiding complications is fairly straightforward, but sometimes difficult to achieve with blood glucose control, blood pressure control, and lipid management. In America right now, 34 million people have diabetes, and about 90% of those have type 2. This is between 8 and 11% of the population. We expect about 1/3 of the population to have diabetes by 2050. If I'm still working in 2050, something went really wrong with my plan. There are over 1 million new cases per year, and 96 million people have prediabetes. And that's important because about 10% of them convert to type 2 diabetes every year. And then there are racial, ethnic, and geographic disparities. Diabetes also increases with age. With age is a risk factor for type 2 diabetes. For adults age 65 and older, 25% have prediabetes or diabetes. Diabetes diagnosis is universal around the world. Normal blood sugars are seen here, as are normal A1Cs, prediabetes range blood sugars and A1Cs, and diagnostic values for blood sugar values and A1Cs. Tight blood glucose control may not be appropriate for all older adults with diabetes. Older adults with diabetes are a fairly heterogeneous population, but we do want to avoid hypoglycemia and hyperglycemia, which leads to falls and mental status changes. And hyperglycemia can lead to dehydration and promotes infection. For more complex older adults, an A1C of less than 8 may be a more appropriate goal than the goal for younger adults of less than 7, so that we can avoid hypoglycemia. This is the current American Diabetes Association algorithm for medications in type 2 diabetes. And I'll blow this up a little bit and highlight some themes. We assess different risk factors in addition to healthy lifestyle behaviors, diabetes self-management, education and support, and social determinants of health. Those with atherosclerotic cardiovascular disease or a risk for that should be on a GLP-1 medication or an SGLT2 medication or both. Of course, GLP-1s are well known right now for weight loss drugs, and SGLT2s also prevent heart failure. Chronic kidney disease is similar to these other risk factors in that persons with chronic kidney disease should be on an SGLT2, a GLP-1, or both. Efficacy for weight loss, of course, is the province of GLP-1 medications, and efficacy for glucose lowering includes GLP-1s and insulin. This is the insulin algorithm. I'm not going to spend a lot of time on this. But basically, it walks you through how to introduce insulin to a person with type 2 diabetes, what the original dose is, what your target dose would be, and how you would titrate that insulin. There are many other non-insulin type 2 medications that are used in diabetes. Metformin is still a good drug. It's cheap. It's an initial drug for many, has no inherent hypoglycemia, and has positive long-term data. Sulfonylureas are medications that I use less all the time. They're cheap, they're potent, they can cause weight gain and hypoglycemia and have renal considerations, so often not used in this day and age. Thiazolidinediones likewise are not used very often anymore because of the weight gain potential, but they do not have any hypoglycemia and they are appropriate for people with fatty liver disease. DPP-4 inhibitors are kind of falling off the radar as well. They're not that potent, they are weight neutral, and they may actually cause CHF, which is a problem in those with diabetes. SGLT2 inhibitors, of course, are potent, have some weight loss. They're not without some caveats, including UTIs and yeast infection and lower blood pressure. And they have positive cardiovascular benefit and positive renal benefit. And glucagon-like peptide 1 agonists are injectable for the most part. There are some orals. They're potent. They produce weight loss. They're not without risk, including pancreatitis, muscle mass loss that Dr. Wyrock will cover. But these drugs do have positive CVD benefit and positive chronic kidney disease benefit. In older adults, we should avoid sulfonylureas due to hypoglycemia, and we need to consider age-related renal disease. Age is a risk factor for renal disease as well. It's not always exclusively from the diabetes. And many medications can't be used in advanced age-related or diabetes-related renal disease. We need to be mindful of polypharmacy, and a single daily injection of basal insulin may work for many patients. Stringent control is not usually needed, particularly for those in long-term care. SGLT2s, as I pointed out, frequently have UTI and yeast infection complications, and GLP-1s often have GI side effects. So these are not always terrific choices for older adults, even though they may have cardiovascular disease or chronic kidney disease. And this is done on a case-by-case basis. Older adults who are functional, cognitively intact, and have significant life expectancy should receive diabetes care with goals similar to those developed for younger adults. If we have somebody who's ambulatory in the community and in good health, there's no reason why we shouldn't treat them fairly aggressively. For some older adults, these goals might be reasonably relaxed and individualized, but we still want to avoid hyperglycemia and hypoglycemia. And for many older adults, we need to think about renal disease, cardiovascular disease, and congestive heart failure as considerations. Blood pressure is an important part of diabetes management, as about 2/3 of all adults with diabetes will have hypertension. Blood pressure should be measured at every visit. Sometimes we do it twice. The target blood pressure is listed here, less than 130 over less than 80 if it can be safely attained. And weight loss treatment for hypertension should be considered if blood pressure is over 120 over 80. Lowering blood pressure reduces cardiovascular disease and kidney disease, And we need to watch for orthostasis, as this can lead to falls. Overly aggressive blood pressure management is not appropriate for many older adults, especially those with orthostasis. Beta blockers and some calcium channel blockers can decrease pulse or affect maximum pulse rate, which can be problematic. And looser blood pressure goals like 150 over 90 might be more appropriate in those who have fall risk. Lipid management, likewise, this is a very common issue in adults with diabetes. About 2/3 of adults with diabetes will have cholesterol disease. For patients aged 40 to 75 without atherosclerotic cardiovascular disease, most of them should be on a moderate intensity statin. And this is not only an ADA recommendation now, this is also an American Heart Association and American College of Cardiology recommendation. Those adults over 75 who are already on statins, it's reasonable to continue those. In adults over 75 who've not been on a statin, but they have a cardiovascular event, it might be appropriate to initiate statin therapy. So a summary of targets in older adults is A1Cs can often be reasonably relaxed with a target of 7.5 to 8.5 with little or no hypoglycemia. But some who are ambulatory and active in the community may warrant tighter control. Blood pressure likewise may warrant tighter or less rigid control. Lipids, statins for most, perhaps case by case after age 75. And aspirin benefit may tilt toward risk in older adults, especially with GI bleeding and falls. And we need to know the renal status for many diabetes medications. Diabetes labs, typically A1Cs, are done 2 to 4 times per year. This reflects glucose control over the previous 3 months. Chemistry panel, 1 to 2 times a year and as needed. A urine for microalbumin annually in those without renal disease. A complete blood count annually, especially those who are on aspirin or have renal disease. And lipids for monitoring compliance. Celiac screening should be done in type 1 diabetes periodically, as about 10% of those with type 1 have celiac disease. And likewise, about 10% of those with type 1 have thyroid disease. So it's important to think about type 1 diabetes in older adults as well. This is a very fast-growing population of persons with type 1, as people with type 1 are living longer than ever. A diabetes foot exam is cornerstone to every visit. This includes a visual inspection and an annual complete foot exam. And there's excellent resources on the Indian Health Service website for foot care in diabetes. And any provider can look at feet in appropriate settings. Why is pre-diabetes important? Well, it's very common. These are people with blood sugars who are abnormal but not high enough to be diagnosed with diabetes. Lifestyle can prevent over half of pre-diabetes cases converting to type 2 and the complications that go with it. And I know Dr. Wyrock would agree that the magic numbers seem to be 150 minutes of exercise per week with a weight loss of 5 to 7% of body weight at minimum. Lifestyle interventions are very important, and persons with prediabetes should be referred to a diabetes prevention program. There's no magic eating pattern for people with prediabetes. Lower carb, lower calorie, Mediterranean diet, heart healthy are all appropriate. Optimal nutrition and protein intake is recommended for adults, and this is very important for those on GLP-1s. And Dr. Wyrock will spend more time on this topic. There's great evidence supporting diabetes prevention that's now 25 years old, the Diabetes Prevention Program, and the Finnish study that were both published in New England Journal of Medicine. So we know that these interventions prevent conversion of prediabetes to type 2 diabetes by about 50%. We need to screen for other comorbidities in older adults, including neurocognitive dysfunction, psychiatric conditions, cardiovascular disease, cerebrovascular disease, hypertension, and renal disease, as well as musculoskeletal conditions, which Dr. Wyrock will focus on, as well as neuropathy and vision. And any provider can stay aware of any or all of these in the appropriate setting. Older adults with diabetes are also at high risk for polypharmacy, urinary incontinence, which can be worsened by some medications like diuretics or SGLT2 inhibitors. Persistent pain from neuropathy or arthritis is very common, as is vision and hearing impairment, as well as fall risk. Screening for early detection of mild cognitive impairment or dementia should be performed for adults 65 years or older, or those with symptoms, at the initial visit and annually as appropriate. I'm now going to turn it over to Dr. Wyrock to cover her section on the role of the physical therapist in diabetes care.
Hi, everyone. We're going to focus on the role that the physical therapist has in treating patients with diabetes. I'm sorry about some of these graphics. I'm not sure why they always show up like this, but the first thing that a physical therapist is responsible for is screening for barriers that can prevent a person from participating in a change of lifestyle. So it's really important to screen for psychosocial factors like depression, anxiety, disordered eating, and dementia. And there's lots of different outcome measures that can be utilized to try to help with this. One of the best ones for dementia and cognitive disorders is the mini mental status exam. It's been validated in older community dwelling adults, hospitalized and institutionalized adults. And then the brief psychiatric rating scale for anxiety, depression, and suicidal ideation is also a good outcome measure that somebody can look at. Next slide, please. Can you advance the slide, Eric? Thank you. Also, keeping in mind socioeconomic factors and general complications that a patient could have when they start an exercise program. So, for example, do they live by a park? Are they in a safe neighborhood where they could walk outside? Are there sidewalks that are accessible to them? These are all important things to consider if we're trying to help this person become more active, because again, we want to try to remove as many barriers as possible in order to make sure that these patients are able to be more active. It's really important that on the first visit, which I'm sure if you're a physical therapist or a healthcare provider, you are doing this, but monitor blood pressure, make sure you're checking glucose at the initial visit so you get a good baseline. If you don't have a glucose monitor in your clinic, I highly recommend getting one. Also, in the history, ask them about their A1C and what their typical glucose is to see if they're checking it regularly. A lot of times, some of these patients are very avoidant. They may be avoidant of what their numbers may say. And so, educating them about the importance of checking their glucose regularly and monitoring their response to physical activity is really important. Making sure that you're asking them about what they're eating, because what they eat will affect their control and their diabetic control, as well as if weight loss is their goal, it could affect that. And now GLP-1s are a huge medication that have really helped this population, but we're finding that if that your people aren't getting the nutrition intake that they need in order to really build healthy muscle mass. So again, making sure that they're getting good protein intake, and you're asking them what they're eating so that you can help them make adjustments in their diet. Next slide, please. Making sure that we are asking about cardiovascular complications. And these include peripheral vascular disease, eye disease, autonomic neuropathy. Dr. Johnson talked about the foot exam. We want to do a regular foot exam and make sure that our patients are getting regular foot exams because we want to prevent ulcers and amputations. And of course, having foot ulcers and amputations can have an effect on the lifestyle interventions that we want to try to encourage our patients to undergo. And then with retinal disease, this has implications for exercise. We wouldn't want to be prescribing jumping type activities or high impact activities to patients who have that type of eye disease. Next slide, please. Dr. Johnson talked a lot about kidney disease and how that can have implications for what type of medication we're prescribing to patients. We also want to make sure that it's not getting missed. So we're screening for it in the clinic. We obviously won't have kidney labs, but you can ask a patient, have you been monitored for kidney issues in the past? And if the answer is no, then of course we would want to make sure that we are talking to their primary care physician to make sure that this is something that is not being missed. We want to make sure that we're screening them for peripheral neuropathy and skin breakdown, because if somebody does have peripheral neuropathy, it's going to affect their balance. It's going to make them more at risk for falls. They may have more chronic pain, and they might be limited with what type of exercise that they can do, or you might have to prescribe exercise differently. And then, of course, we don't want to promote skin breakdown because people heal slower when they have diabetes. And so we want to make sure that they have healthy skin tissue as well. Next slide. Peripheral vascular disease can lead to ulceration of the feet, and so we want to make sure that we're screening for that. And this is a device that can be utilized to help screen for that, as well as using Weinstein monofilament testing to really quantify what peripheral neuropathy and sensation loss that these patients have. Next slide. And then, of course, the thing that I think is most important from a physical therapy aspect is screening for musculoskeletal complications. These patients are at risk for lots of joint problems, including arthritis, deformity of those joints, which then can impact the amount of pressure that they have on their feet, which then can lead to ulceration of the feet. Making sure a lot of these patients have lack of range of motion. So making sure we're checking range of motion in the joints, and we're really prioritizing mobility work in these patients, especially within the shoulders, the hands, and the ankle and foot. We know that if these patients are on GLP-1s, that they're going to be at risk for sarcopenia. That is one of the side effects of GLP-1s. When they've done studies on this, they find that weight loss is actually reversed of what normal weight loss would be. So instead of losing, 30% of 30% of muscle mass, 60% of fat mass, which is what would be normal in regular weight loss, they're finding it is the reverse. They're losing more muscle mass than they are fat mass. And so as physical therapists, it's our responsibility to make sure that we're really screening them for these musculoskeletal problems, because we know that if we're dosing exercise correctly, especially with resistance training, we can actually decrease significantly how much muscle mass loss these people on GLP-1s are losing and targeting more of that fat mass, all just with how we dose exercise. And so a lot of times people with diabetes, not only are they going to have a loss of strength and muscle mass, especially in their lower extremity, but add GLP-1s to it, and that is exacerbated. So really making sure that we're doing this. And you can screen function through, a 6-minute walk test, a 2-minute walk test, 5 times sit to stand. There's lots of outcome measures that you can utilize to look at that. Next slide. One of the deformities that patients with diabetes are at risk for is hyperextension of their MTP joint. And what happens with this is that there's an increase in the amount of force and recruitment that happens with the extensor digitorum longus muscle during ankle dorsiflexion because of the weakness within the ankle. And that leads to poor recruitment of the intrinsic muscles of the foot, which then causes that MTP joint to extend, which is being shown here in this MRI picture. And so, of course, when you have this extension of the MTP joint, it's going to decrease the surface area of the bottom of the foot, which is then going to increase the risk of ulcerations and balance issues within the foot. And so as a physical therapist, it's really important that we're prescribing stretching to this joint and stretching to the ankle and mobility, doing joint mobilizations to this joint and to the ankle so that these patients are decreasing their risk for having this be a permanent permanent change. Next slide. We want to make sure that if a patient is having pain, that we're addressing it. Because again, one of our goals is to get these patients to move their bodies more. And a lot of times, because of their higher risk for arthritis, the pain issues that they have, that's going to be a limiting factor in them engaging in exercise. So really utilizing our whole skill set as physical therapists, or if you're not a physical therapist, but you work with a physical therapist in your health system or in your clinic, making sure that these patients are getting referrals to physical therapists so that they can address their pain problems. Because if a patient is wanting to do a walking program, but it hurts when they walk, they're not going to do it, and it's not going to be fun for them. So trying to, again, decrease as much barriers as we can so that these patients are changing their lifestyle and also enjoying those changes so they can live longer, healthier lives. Next slide. The diabetes team is made up of many providers. So of course we have people like Dr. Johnson, who's specializes in treating these patients. But we also have other providers that are helping make this team move and making sure that these patients are getting a holistic view of their health. So we're addressing all of the systemic complications that come with diabetes. Diabetes just doesn't affect the endocrine system. It affects every system of the body. And so getting the right specialties and providers in to help these people. And we've talked about the eye issues that these patients can have. So making sure you have an ophthalmologist or an optometrist on their side, a pharmacist to make sure that the polypharmacy issue is being flagged if that's happening, a nephrologist for their kidney health, a cardiologist for their cardiovascular health, since we know that that's the number one leading reason that patients die from this disease, making sure we're addressing the mental health component as well as the physical component to getting them to exercise more. Next slide. And then, of course, we have a diabetes nurse educator. We have who are certified in educating these patients on the changes that they need to make. And having one of these on your team is extremely important. And having one that understands how the team works together will really optimize the outcomes that these patients have. Dietary changes are very important. And so making sure we're referring these patients to a dietitian, a registered dietitian who can help them eat better and keep things in their house that will help maintain this lifestyle change. That's really important. And then, of course, the patient is one of the most important parts of the team. If you don't have buy-in from the patient, the changes aren't ever going to happen. Next slide.
Thanks, Dr. Wyrock. Let me share a little bit about my practice in the post-COVID world. I'm still doing about 50% telehealth to many rural areas, including Rugby, War Road, Roseau, Devil's Lake, Cavalier, and a couple of other places. Persons with diabetes are known to be high risk, and patient acceptance of expanded telehealth service was nearly immediate. Relaxation and modification of building and coding rules have made this a viable option. Patients will likely continue to demand this service in the future, and that's been my experience. Going back to normal seems unlikely, and we need to consider some elements that must be done in person, like comprehensive foot exams, and typically I rely on their primary care provider to do that. And many people have some kind of blend of virtual and in-person visits with their primary provider and myself. Typical visits that we're doing now from our diabetes clinic include virtual visits where the patient is often in their home or at work in a private space. I can listen to their heart and lungs with an electronic stethoscope. Older adults can do this too, but often need a facilitator. At home, that can be a family member or friend, and in the clinic can be a nurse or medical assistant, or sometimes the certified diabetes care and education specialist.
So now we're going to talk about the role of physical therapists in the treatment for patients with diabetes. Dr. Johnson covered a lot of the medical management of these patients, but now we need to think about how are we going to get these patients active and get them engaged in moving their bodies so that they can improve their overall function and health. Well, right now, 80% of patients who are referred to outpatient physical therapy have diabetes, risk factors for diabetes, or prediabetes. Yet only 2% of these referrals are actually for diabetes as a primary condition. And there's a high prevalence for these of these patients in other settings as well, besides outpatient. And so we know that diabetes impacts most body systems that produce movement, which are in this graphic here. And physical therapists address all of these body systems. We really want to encourage other providers to make this referral for their patients, especially if their patients are having pain that is limiting their ability to become more active. Next slide. Physical therapists provide guidance on physical activity participation, and we know that 150 minutes per week is kind of the magic number. And really, that amounts to about 20 to 30 minutes of activity every day. It's really not a lot of activity. And I think when people think about 150 minutes, they're like, oh my gosh, that's so much time. But really, it's 20 to 30 minutes per day. And how many times are we sitting on our phones scrolling Instagram for 20 to 30 minutes at a time? It's time in our day that we can really dedicate to making our bodies healthy. And we know that even just something as simple as brisk walking makes a huge difference in the development of complications from diabetes, and it can also improve high blood pressure. We want to encourage diets higher in whole grains and leafy green vegetables and decrease the amount of refined grains, processed meats, and sugar sweetened beverages, which is something that I always educate my patients on. And if it's something they're really struggling with, then I'm communicating with their dietitian as to how we can work together to make sure they're successful at eating the things they're supposed to eat and moving their bodies the way they need to move their bodies. Next slide. So the very specific recommendation from the American Heart Association and the American Diabetes Association is 150 minutes a week of moderate to vigorous intensity aerobic activity spread over 3 days per week with no more than 2 consecutive days without activity. So that's kind of the overarching specificity of how we want to think about prescribing exercise. 2 to 3 sessions per week of resistance and exercise training is recommended. And I would say that if somebody's on a GLP-1, this is something that's going to be extremely important, because if somebody has sarcopenia and diabetes, then they're going to be at the double of risk of falling. And we know that falls are the number one killer of adults as they get older. And so we want to make sure we're preventing falls, we're improving strength, and if they are on a GLP-1, that we're mitigating the sarcopenia that can happen by prescribing the right amount of resistance training. We talked about why flexibility and balance training was really important. And also just telling patients that we need to just decrease how much we're sitting and encourage physical activity throughout the day. Basically, we want to customize the program to what the patient likes to do and what their goals are, and then also what type of complications they are at risk for and how can we mitigate those complications. Next slide. These are just some studies that talk about the effect of exercise on hemoglobin A1C, and you can go to the next slide. And it impacts it considerably. You can almost decrease hemoglobin A1C by a whole point by just implementing regular exercise. So this is a really important step. And if combined with dietary recommendations, that relationship becomes even stronger. Next slide. So the specific exercise prescription in older adults for diabetes, according to the literature, is that the exercise needs to be structured exercise with supervision consisting of aerobic training, resistance training, or the combination of the two for at least 12 weeks with a dosage of 150 minutes or greater per week. And that is what the literature shows actually improves type 2 diabetes outcomes and control. Next slide. This chart just shows different types of exercise and the prescription that we would utilize for those older adults. So it's divided through by aerobic exercise, resistance training, and flexibility and balance. And it talks about how many repetitions a person should get to, as well as what should they be feeling to make this actually an effective exercise. The next line is duration. How long should this patient be going through this exercise, and what intensity and frequency should they be utilizing it, and what's the progression? So you can utilize this chart to help guide your prescription depending on the patient you're seeing. Next slide. This is an example program of stretching that I like to give my patients with diabetes, where it focuses on the major joints of the muscle, specifically in the lower extremity. I think that a lot of people forget about the feet and forget about the toes in patients. So really making sure that we're really addressing foot and ankle flexibility in these patients to not only ensure that we're improving their balance, but also decreasing pain that may come with these issues. Next slide. This is a study that was done a while ago, where they looked at non-weight bearing programs versus weight bearing programs in people with diabetes. And this was the non-weight bearing group that they had in the study. Basically, what they were trying to determine is if somebody is at risk for a wound situation, is it safe for them to do weight bearing exercise? And if you have a patient that you're concerned about that issue, where maybe they do have an open wound on the bottom of their foot and they can't do something like they can't do walking, or they can't do something standing. These are some example exercises that a patient can do if weight bearing is contraindicated for them. Next slide. And we're just going to kind of go through each one. This is for balance and strengthening. Next slide. And various levels for that. And this would be the weight bearing group. And this is just the protocol that was used in this study. And next slide. When they looked at the differences in the amount of foot ulcers between the weight bearing and the non-weight bearing group, there weren't any differences. And so based on the results, this group concluded that weight-bearing exercise was safe for patients who had diabetic neuropathy, pending that they had no foot wounds at the start of the program. So again, you want to make that determination based off of your patient's individual basis. Next slide. This chart goes well with what Dr. Johnson was talking about earlier about exercise considerations for older adults who are on medications for diabetes and other comorbidities. I think that all healthcare providers need to understand what medications cause hypo or hyperglycemia, and I think that this table does a really good job of describing what those are and how the dose of those medications may need to be adjusted by the physician, or maybe things that you need to be thinking about when you're prescribing exercise to a patient. Next slide.
So now we're going to move into a case study as we get close to wrapping up for the afternoon. This is a 67-year-old male with a 15-year history of type 2 diabetes who lives in the community with his spouse and still working as a supervisor at a local engineering firm. He has left knee osteoarthritis, chronic kidney disease, hypertension, dyslipidemia or cholesterol disease, and peripheral neuropathy. Medications include Detamir, which is a long-acting insulin, injected daily, and dulaglutide, which is a GLP-1 agonist. Also on metformin, an ACE inhibitor, lisinopril, for blood pressure. We can see that this person has some orthostasis, which can be a fall risk, is on a statin appropriately, and is on aspirin. Patient goals are to improve control of their diabetes, and this person is currently regularly checking their blood glucose, which ranges from 60 to 220, and occasional overnight lows. Likes to go for walks with spouse, but is limited by knee pain.
And so, one of the ways that we want to manage this patient from a physical therapy perspective is that we want them to be walking. They enjoy doing that, but they're not doing it because their knee hurts. And so, we're really starting our treatment by focusing on that knee pain and trying to improve their range of motion and their mobility. The less mobility that a patient has, especially a patient with diabetes, has in a joint, the more painful that joint is going to be. So you have to address those range of motion and mobility deficits before you can really start a good strengthening program that's going to be really effective in helping them achieve the goal, in this case, of walking for the patient so that they can be active. So once you're improving that knee range of motion and the mobility of the knee, then we can start doing some kind of non-weight bearing aerobic program. And as that knee pain is improving and they can start tolerating more weight bearing activities, then we can start transitioning them to weight bearing activities. Now, this patient is on a GLP-1, so we want to make sure that we are integrating resistance training into their program so that we are limiting how much muscle mass they're losing as they're on this medication and getting their and having their diabetes control. So we want to address their strength deficits from just not really moving their bodies, but also from using that medication with a good resistance program that they're doing regularly. We want to educate them on checking their feet. If they're going to go for walks more, they need to make sure that their feet are not are getting blistered or becoming damaged. And then we want to address those balance deficits that come with it. And ultimately, our goal is to make these patients self-sufficient so that they are able to go out on their own and do their exercise program without us having to be there to supervise them. And we know from evidence that in order for this to be successful, they have to start on the supervised program and gradually get weaned off the supervised program.
So in conclusion, older adults with diabetes are a fairly heterogeneous population and targets need to be individualized. Physical therapists like Dr. Wyrock are an important member of the diabetes care team to continue to screen for complications and comorbidities, and treatment should focus on primary and secondary prevention of complications and comorbidities that would lead to functional impairment. Lifestyle change is a goal when treating people with diabetes, and we don't want to forget about that. And we want to refer to appropriate members of the healthcare team as needed.